So hello friends. So we'll begin with we have 25 MCQs every day. So the first question is, processing of tactile stimulation occurs in Broadman's area, and the options are 3, 1, 2, 4, 6, 44, 45, or it's 41, 42. I will repeat the question. It's processing of tactile stimulation occurs in the Broadman's area, and the options are 3, 1, 2, 4, 6, 44, 45, or it's 41, 42. Basically, Broadman's area, you know what is Broadman's area. It's in brain, you know it's a Broadman's area will be there, and there are around 50 areas of Broadman's area in the brain. So the question is, processing of tactile stimulation occurs in Broadman's area, and the options are 3, 1, 2, 4, 6, 44, 45, or it's 41, 42. No, answer is it's not. No, it's not 41, 42. It's 3, 1, 2. So we have to remember that it's a 3, 1, 2 the right answer here. It's a factual question. You can't tell anything. Next we have a pathology question. I think it's a image. It's an image based question. 3, 1, 2 is the right answer. So next we have, it's a pathological question. It's it's of a lung. Identify the structure marked as H. But I cannot show you the image. So I can just basically tell we have bronchus. Basically in lung we start with the bronchus. Then it will be I'm confused. It's bronchus, bronchi, then bronchioles, then there will be alveolar sac, and then it will be alveoli. Alveolar ducts before that. So it's an image based. I cannot show you that, but the H shows alveolar duct. That was the right answer here. So next moving on to this, it's a 34-year-old woman presented with generalized weakness and lightheadedness since 2 weeks. Peripheral smear shows RBC fragment, and blood investigations were notable for decreased hemoglobin, increased indirect bilirubin, and LDH. So which vitamin deficiency is associated with this condition? Basically, its options are A, E, D, K. I will repeat. It's a 34-year-old woman with a generalized weakness and lightheadedness since 2 weeks. Peripheral smear shows RBC fragments, and there will be less hemoglobin, increased indirect bilirubin, and LDH. So which vitamin deficiency is that? Options are A, E, D, K. Anyone want to try this? Okay, basically it's E. That is vitamin E is the right answer. This is the case scenario of hemolytic anemia. Why? See, there is generalized weakness. That all is okay. Weakness will be there in every condition, but there will be RBC fragments as shown in the microscopy, and hemoglobin will be decreased. Bilirubin will be increasing. Bilirubin increases when there is more hemolysis, and hemolysis is there will be more bilirubin because of liver will make that. So an LDH. So it's a case of hemolytic anemia, and it is associated with deficiency of vitamin E. So you have to remember here, when there is a hemolytic anemia, there will be a deficiency of vitamin E. Vitamin K deficiency is not there. Vitamin E is. I know you were talking vitamin K because of toxicity of vitamin K causes hemolysis, not deficiency. So there will be, if there is more vitamin K, there will be toxicity, and then it will cause hemolysis, but not deficiency. So the answer here is vitamin E is the right answer. Next question we have, it's again a pathological question. Its question is, a 60-year-old man was referred with severe anemia and hepatosplenomegaly. Peripheral smear showed teardrop cells, mutilated RBCs, and giant abnormal platelets. Bone marrow aspirate could not be obtained despite multiple attempts. Hence a bone marrow biopsy was done. The findings is given below. What is the most accurate diagnosis? So I'll just repeat what is the case scenario. It's a 60-year-old, severe anemia, hepatosplenomegaly. Main you have to remember, there is a teardrop cells in the peripheral smear, and mutilated RBC, giant abnormal platelets, and bone marrow biopsy was done. So in the bone marrow biopsy, it was basically this. I will just tell you, it is fibrosis is seen. There is a marrow fibrosis here in the bone marrow. Usually, what is the diagnosis if you can tell from this condition? And the options are polycythemia vera, essential thrombocytopenia, and primary myelofibrosis, or it's a chronic CML basically. Anyone wants to answer this if you can? It's a case of what? There is fibrosis seen in the microscopical picture of bone marrow biopsy. Okay, no one wants to answer. Let's actually see. That is a primary myelofibrosis is the right answer. Usually, because of myelofibrosis is seen in the clinical, that is the microscopic picture, and the clinical findings and the history of a dry tap on bone marrow aspiration and diagnostic of that is the primary myelofibrosis. In this condition, the neoplastic proliferation of the hematopoietic stem cells results in increase in abnormal proliferation of the megakaryocytes. So basically seeing the image, microscopic image as well as the teardrop sign, you can tell it is a primary myelofibrosis, and that to dry tap. If it is a dry tap, you are not able to aspirate, then you can tell. Next we have it's an 80-year-old man with rectal carcinoma presented with features of intestinal obstruction. So how will you manage this patient? So I will repeat, it's a 80-year-old man, rectal carcinoma patient, and there is a intestinal obstruction is there. So how will you manage this patient? Options are Hartmann's operation, anterior dissection, abdominoperineal dissection, or it's a total mesorectal excision. I will repeat, it's a Hartmann operation, anterior dissection, abdominoperineal dissection, or it's a total mesorectal excision. Anyone wants to try this? 80-year-old carcinoma, rectal carcinoma with intestinal obstruction. If you want to try this, I think no one wants to do it. Okay, the answer there is A. Right, the Hartmann's operation we do when there is a rectal carcinoma. Why? Because in elderly patient it is morely preferred. It is elderly and frail patient in whom there is a concern about the anal sphincter function or the viability of the anastomosis. Usually in elderly patient we preferred Hartmann's operation other than the other operation. So we can't do a excision. It's a Hartmann operation. So we can't do excision, but it's in elderly patient. That's why it's a Hartmann operation is preferred, because there is a concern about the anal sphincter function and viability of the anastomosis. So next we have it's a pediatric question. Next we have it's a 2-year-old boy with Noonan syndrome, presents with hepatosplenomegaly and lymphadenopathy. So you are suspecting juvenile myelomonocytic leukemia. So which of the following is not seen in this condition? So which of the following is not seen in this condition? And the options are GM CSF hypersensitivity, absence of Philadelphia chromosome, poor prognosis, or it's an increased HbA2 level. I repeat, it's basically Noonan. It's a case of Noonan syndrome. That too, it's a 2-year-old boy, hepatosplenomegaly, lymphadenopathy, and he was suspecting juvenile myelomonocytic leukemia. Which of the following is not seen in the juvenile myelomonocytic leukemia? Basically, they are asking. And the options are GM CSF hypersensitivity, absence of Philadelphia chromosome, poor prognosis, or it's increased HbA2 level. I also don't know, someone is there, but it's a child, not anyone adult. So where I was here. I know NEET PG got postponed, so that's why you are all chilled out. I am also, but we have to continue. So it's a 2-year-old boy with a Noonan syndrome, present with you with hepatosplenomegaly, lymphadenopathy, and he was suspecting a juvenile myelomonocytic leukemia. So which of the following is not seen in this condition? So GM CSF hypersensitivity, absence of Philadelphia, poor prognosis, or it's an increased HbA2 levels. So okay, no one wants to answer. The answer is increased HbA2 levels is the right answer here. It is seen in juvenile myelomonocytic leukemia. So there is a diagnostic criteria which you all know, that is the hepatosplenomegaly, lymphadenopathy, pallor and skin rash is the basically it's a clinical features of this condition. So in leukemia you have to remember everything. That is a problem. But no option. Next we have it's identify the following instrument. How will you identify? Basically it's an instrument of thermometer, and you have to identify what it is. That is a globe, Jason's wet bulb, or it's a thermometer. Sorry. So how will you identify the thermometer? That is basically, if it's a mercury thermometer, we know how to identify mercury thermometer. And it's a globe, Jason and wet bulb. Here the image is basically of a such thermometer. That is basically it is mercury or alcohol. There are different types. Such thermometer again someone is crying. I don't know why. Such thermometer is basically both mercury and alcohol, and it measures maximum and minimum air temperatures reach over the period of time. So basically it has both mercury and alcohol in this thermometer. There are different types. I think today everyone wants to interpret. So next question we have the MRI spine of a patient is shown below. What is the characteristic deficit seen in this condition? Anyone? How will you tell? I don't know. All are image-based questions. I'll just repeat. It's a MRI spine of a patient as shown in the below. What is the characteristic deficit seen in this patient? So Okay, I'll just tell it's a case of syringomyelia. So now you can tell it's a case of syringomyelia, and now you have to tell what is the characteristic deficit seen in this condition. And the options are pyramidal pattern of weakness, around the clock pattern of weakness, suspended distribution of sensory deficit, or it's a segmental pattern of weakness. So yeah, if you can tell in syringomyelia what will happen. Anyone, if you want to tell in syringomyelia? Okay, I will just tell the answer. There is suspended distribution of sensory deficit. Basically, yeah, it's the MRI is showing there is a lesion here in the spinal cord, and yeah, it is located at the C6-C7 in the cervical spine. So yeah, if it's a C6-C7 cervical spine, there is a lesion, you can suspect syringomyelia, and you can tell it's a deficit is in the sensory deficit. That is in the suspected distribution of sensory deficit. It presents as a central cord syndrome with unilateral sensory loss in the hands initially, and later all over the body it is there. There is a loss of pain and temperature. So yeah, it's a case of syringomyelia. Next we have TIS classification is used for the staging of what? And it's a multiple choice question, so I repeat, TIS classification is used for the staging of ductal carcinoma in situ, lobular carcinoma in situ, Paget's disease, or it's an inflammatory carcinoma, or it's a colloid carcinoma. It's a multiple choice question. So I'll just repeat, TIS classification is used for the staging of DCIS, that is ductal carcinoma in situ, lobular carcinoma in situ, Paget's disease, or it's an inflammatory carcinoma, or it's a colloid carcinoma. So yeah, if you want to tell, it's a multiple choice question. So yeah, answer is 1 and 3. 1 and 3, that is the ductal carcinoma in situ, and Paget's disease is basically seen for a TIS classification. Yeah, I know I'm just saying the answers, but yeah, it's a factual question. TCIS is for ductal carcinoma, and that is for Paget's disease. So yeah, you just have to remember this all. So TIS is basically Paget's. Yeah, Paget's also is there, and as well as ductal carcinoma is there. So DCIS and Paget's both are there here. So yeah, TIS classification is used for TCIS, DCIS as well as Paget's disease. So yeah, now it's a big question, but yeah, it's an interesting one, I think. Yeah, you have been called to see a 10-year-old child in the emergency room with complaints of fever and vomiting for the past 3 years. On examination, the child has tachycardia and there was significant postural hypotension. Upon investigations, hyponatremia and hyperkalemia were present. So you suspect the adrenal insufficiency in this condition, and which of the following is most likely organism grown in the blood culture? So yeah, I'll repeat again. It's a case of 10-year-old child, complaints of fever, vomiting past 3 days. Examination, tachycardia is there, postural hypotension, hyponatremia, hyperkalemia were present, and suspected it is adrenal insufficiency. So which of the following is the most likely organism in the blood culture? And the options are Haemophilus influenza, Neisseria meningitidis, Mycobacterium tuberculosis, or it's a Corynebacterium diphtheria. So yeah, if you want to answer this, Haemophilus influenza, Neisseria meningitidis, it's a TB, or it's a case of Corynebacterium diphtheria. So yeah. Anyone? Okay, the answer here is it's a B, basically Neisseria meningitidis, because it's a case of meningitis. It's a case of meningosemia. What they have given it's a case of meningosemia, which is caused by Neisseria meningitidis. See, if you have a patient with meningitis, you will suspect there is rigidity also, but in children it's not that much. But yeah, it's a fever will be there. So yeah. So it's a case of adrenal insufficiency in children is meningosemia, and it is caused by Neisseria meningitidis. So the most common infectious cause of addiction disease in India is TB. That is all that it's basically for your one-line question it is. So yeah, the answer is Neisseria meningitidis, and it is basically meningosemia is the diagnosis here. Next we have, this one is easy, I think you can answer this. It's a subhyaloid hemorrhage is boat shaped, crescent shaped, round, or it's a flame shaped. I will repeat, subhyaloid hemorrhage is boat shaped, crescent shaped, round shape, or it's a flame shaped. So yeah, if you can just guess A, B, C, D. Anyone? You want to just guess this answer? Subhyaloid hemorrhage, yes, it's an ophthalmic question. It's a boat shaped, crescent shaped, round shaped, or it's a flame shaped. Yeah. Anyone? Basically, subhyaloid hemorrhage, you know, it's an ophthalmic question. It will be hemorrhage will be present in the. It's basically between the posterior vitreous and the internal limiting membrane of the retina. So yeah, there is a hemorrhage in the retina, and that too between posterior B. No, it's A. It is boat shaped. You have to remember this. It's a boat shape or it's a dome shaped. So yeah, it's a subhyaloid hemorrhage, and that too it's a hemorrhage that is bleeding present between the posterior vitreous and the internal limiting membrane of the retina. So yeah, and they have given the image. You can see that. See all the okay. Next we have, it's a 6-year-old child requires an endotracheal intubation. So which is the correct length of tube to be chosen? That is 6 cm, 10 cm, 12 or 15. So yeah, if you know anesthesia, we have discussed this. I think yesterday only we discussed this. It's an anesthesia question. You have to put an endotracheal tube in a 6-year-old child. So what is the correct length to be used? 6 cm, 10 cm, 12 or it's a 15. So anyone? Yeah, yesterday we discussed there was some formula. Yeah, the formula is, and even for the formula here is 12 plus age by 2. So yeah, the age is 6 years old. 6 years, that is, it is 6 by 2 is 3. So yeah, it is 12 plus 3 is 15. So yeah, the right answer here is D, that is 15 is the right answer. So yeah, you have to remember like a formula, it is 12 plus age by 2, that is 15, it comes to 15. So yeah, in children we have to do like that. And you know what is the surest test for endotracheal intubation? You all know it will be ETCO2. If you have read anesthesia, you can know it is ETCO2, which is the surest test that you can consider that you have already been taken by the patient. It is ETCO2. Yeah, next we have, it's a patient with abdominal colic and constipation. On examination, pallor and blue striped lines on gums are observed. So what is the most common mode of exposure to this particular toxicity? So yeah, I repeat, it's a patient who presents with abdominal colic and constipation. Examination, you see a pallor and blue striped lines on gums are observed. What is the most common mode of exposure of this particular toxicity? It's the ingestion of paint, inhalation of fumes, absorption through skin, or drinking contaminated water. So you have to tell what is the what is the diagnosis here, which toxicity I am talking about. Anyone? Abdominal colic, constipation, pallor, blue striped line. Blue striped line is the diagnosis for toxicity. You can tell. Yeah, it's a Burton's line. Burton's line, basically it's that. So it's anyone? Okay, the answer here is actually diagnosis. So diagnosis here is lead poisoning is the case. So yeah. So in lead poisoning you see a Burton's line. Burton's line basically it's that is blue striped lines on the gums, it will be present. So yeah, it's basically because of inhalation of fumes. So B is the right answer. Inhalation of fumes will cause lead poisoning. So I know I am going fast. I'll slow down. So yeah, next is also an image-based question. So which of the following is incorrect regarding the image shown? So yeah, it's an image of, it's a basically flower, and the image is basically, it's an image of an aconite and all varieties, and so yeah, that's the answer. So yeah, it's a case of aconite. So aconite, it's a forensic question, so you have to remember it's a case of aconite. And which of the following is incorrect? So the options are only the roots of these plants are poisonous and it causes AV block. And then we have drug of choice for this poisoning is atropine, or it's mitha zehar is one of the variety of this plant. So yeah, if you want to tell this answer, it's a case of aconite. And what is the wrong answer here? The wrong choice. Options are only the roots of these plants are poisonous, causes AV block. Drug of choice is atropine, or it's mitha zehar, which is one of the variety of this plant. Anyone? Okay, I will tell you the answer is A, that is the option was only the roots of these plants are poisonous. No, it's all the parts of this plant is poisonous. You have to remember it's a case of aconite, so every part of the plant is poisonous. And yeah, it causes a cardiac, it has a cardiac poison. Yeah, it's a cardiac poison, so it will cause the AV block. So yeah, it causes AV block, and drug of choice for this condition is atropine. And the last one was mitha zehar is one of the variety. Yeah, it's a right answer. Mitha zehar is one of the variety. So yeah. Next question we have, it's calculate the half-life of a drug H administered to a patient with a volume of distribution 50 liters and clearance of 0.1 liter per minute. So yeah, every day it comes. This question every day we have to calculate this question. So every day this question comes. So it's drug H. It is given to a patient, volume of distribution 50 liters and there is a clearance of 1 liter per minute. So it's a biochemistry. If you know the formula, then only you can answer this. So we have discussed, it's what is the formula of TF. Yesterday also I discussed it's first order kinetics. So in first order kinetics we use the formula that is TF is equal to 0.693 into VD by CL. So VD is basically volume of clearance and volume of distribution and CL is clearance. So it will be 0.63 into 50 by 0.1. So approximately the answer comes is D, that is 350 minutes with the answer. So so you have to remember this formula. Yesterday also it was there. So TF is 0.693 into volume of distribution by clearance in the first order kinetics. Next we have, it's 500 mg of a drug was administered to a patient. Then 100 mg was cleared in 1 hour. So how much of the drug to be left in his body after 3 hours if the estimation of the drug follows a zero order kinetics. So that was the first order kinetics. It's a zero order kinetics. So in zero order kinetics, in this formula is not that same. So because in zero order basically it's a constant amount which will be going after a T-half, and in first order there was a formula for that. So again I will tell, it's 500 mg of the drug was administered, 100 mg was cleared in the 1 hour. So how much drug would be left after 3 hours? And the options are 200, 300, 400 or it's a 100. So it's a easy question because it's basically they are telling half T-half is 1 hour. No, they are telling it's a 100 mg is going for after 1 hour, 100 mg is going off from the body. So after 3 hours it will be, if it's a zero order kinetics, it will be 300. So because every hour it goes 100 mg. So your answer here it will be 500 minus 300, that is 200 is the right answer here. Because it follows zero order kinetics, a constant amount will go after every time. So next we have 25-year-old woman comes with complaints of greenish vaginal discharge. On saline microscopy, motile flagellated organisms were seen. So what is the best treatment option for her? Options are doxycycline, amoxicillin, fluconazole or metronidazole. So if you can tell what is the diagnosis here, otherwise you will know what is the treatment of choice here. Diagnosis, if you can tell, I'll just repeat, it's a greenish vaginal discharge, and microscopy you have a motile flagellated organisms are seen. So just remember diagnosis. I'll wait for a diagnosis if anyone can tell. Otherwise if you know a diagnosis you can just tell what is the drug of choice. So okay, I will tell it's a diagnosis. Basically it's a trichomoniasis. Now you can tell what is the drug of choice for trichomoniasis. D, it's a trichomoniasis and the drug of choice is metronidazole. It's a oral metronidazole 2 grams that you have to give for this patient. So the treatment regimen what it is there in trichomonas vaginalis is, it's a oral dose of metronidazole 500 mg twice daily for 7 days, or you can also give a single dose of that is 2 gram what I told. So and the male partner should also be treated. I think in bacterial vaginosis also a male partner has to be treated. No, bacterial vaginosis we don't treat. In candidiasis we treat. I think I am confusing between both. Because in one we don't have to treat the patient with the male partner. So next we have which is the following is true regarding depersonalization disorder. And the options are, it is more common after life-threatening trauma, seen in seizure and migraine patients, more common in females, or it's a mean age at onset is 25 years. So I repeat, which of the following is true regarding a depersonalization disorder? And the options are more common after life-threatening trauma, seen in seizure and migraine patients, or it's more common in females, or it's a mean age is 25 years. See, more common in females, I don't think it will be there, because females probably that I'm not telling that. But its answer is, if you want to tell what is most true regarding depersonalization disorder. So anyone? Okay, depersonalization disorder is basically it's an experience of unreality, detachment, or being an outside observer with respect to one's thought, feeling, sensation, body, or actions. Basically, you are detached and you are seeing from the outside. It's not schizophrenia, but schizophrenia has a dual personality. But yeah, in this condition, you see from the outside what you are thinking. So it's an outside observer. So yeah, it's more common after a life-threatening trauma is the right answer. A is the right answer. So yeah, it's not seen in seizure or migraine. It is not common in. It's common in males, I think. Yeah. No, it's yeah. And that's all. No. Sorry. There is no gender discrimination here. Male and female ratio is 1:1, and the mean age is 16 years, not 25 years. So yeah, it's more common after life-threatening trauma. So next question we have, which of the following is not found in alpha granules of platelet? And the options are fibrinogen, PWF, factor 5 or serotonin. So yeah, I repeat, which of the following is not found in alpha granules of platelets? Options are fibrinogen, VWF, factor 5 or serotonin. So if you know which are not there in alpha granules of platelets. So yeah, it's basically the answer here is D, serotonin. Because serotonin is present but not in alpha. It's basically present in delta granules of platelets. So yeah, you have to remember this. It's a factual question. So you have to remember what is there in alpha granules, what is there in delta granules, and yeah, basically you have to remember this. There is no option. So fibrinogen, VWF, and factor 5 is present in platelets. Alpha granules are the platelets. So yeah, next we have a standard handheld dermoscopy at low magnification revealed the following findings in a patient who presented with intense itching. So which of the following medication can be given oral to treat this patient? So yeah, it's like basically we have given an image based question, and I can just tell that it is a patient present with intense itching. I will just tell what is the case. It's a case of scabies. Now you can just tell me what is the drug of choice for scabies, but I cannot show you the image here. So what is the drug of choice for scabies? This I think everyone will be knowing this mostly. Which oral medication you can give, because permethrin was what I know is permethrin is given in topical. So yeah, what is permethrin? No? Yeah, 5% permethrin is given in topical. But yeah, what is the oral drug of choice for scabies? If anyone can tell. The options are gamma benzene hexachloride, lindane, ivermectin or albendazole. Now you can tell. Okay, the answer is ivermectin. Ivermectin is the drug of choice for scabies, oral drug of choice. Next we have, it's a 68-year-old woman who presents with complaints of right-sided facial weakness for 15 days and progressive hearing loss for 2 years. On examination, there is tachycardia and carotid bruit on the right side. Otoscopy was done and it shows a red mass behind a tympanic membrane, and a 24-hour urine collection shows the presence of metanephrines. So yeah, metanephrines is you can tell it's a diagnostic factor here. So which of the following classification system is used for this condition? It's a Lederman's classification, Fish, Austin, or it's a SEDES classification. So yeah, see, because before all this, we just have to tell what is the diagnosis. Because knowing the diagnosis, you won't be knowing which classification we use here. So yeah, I will just tell it's a facial palsy is there, hearing loss is there, a red mass is there behind the tympanic membrane, and tachycardia is there, and the carotid bruit is there, and the positive urine metanephrines is there. So yeah, anyone? What is the diagnosis here? Okay, the diagnosis I will later. It's a glomus tumor. Glomus tumor is basically releases catecholamines, as you know. So because of catecholamines, we can see tachycardia and carotid bruit can be seen. And whereas it is behind the tympanic membrane, so that's why it's otoscopy. You can see a red mass behind the tympanic membrane, and the diagnostic test here is metanephrine in the 24-hour urine analysis collection. That only. So yeah, and the answer will be Fish classification. Fish classification we use for this glomus tumor. So yeah, Lederman's classification we use for imaginary carcinoma. Austin classification we use to classify anatomical defects in ossicular chain, whereas SEDES classification we use to classify atelectasis, or it's a retraction of the pars tensa. So yeah, the answer is Fish classification in glomus tumor. Next we have, which of the following investigation is used to diagnose unicornate uterus? So it's a OBG question. Which of the following investigation is used to diagnose unicornate uterus? It's a multiple choice question, and the options are palposcopy, laparoscopy, HSG or X-ray. I'll repeat, it's a palposcopy, laparoscopy, HSG or X-ray for unicornate uterus. Anyone? It's a easy one. If anyone can just tell which of the following investigation is used for diagnosing unicornate uterus: palposcopy, laparoscopy, HSG and X-ray. Okay, yeah, the answer here is D. That is on the what it was 2 and 3. That is laparoscopy and HSG. So yeah, when you see laparoscopy, you can just go through and you can see it's a unicornate uterus. Whereas in X-ray also there is some that is what to tell. It's a there was some findings in X-ray also. Where it went. Palposcopy, evaluation, X-ray. Yeah, it's a fusiform banana shape tapering at the apex and running into a single fallopian tube. That is the finding here. So yeah, the answer here is 2 and 3. That is the HSG and laparoscopy right answer. So yeah, hysterosalpingography, basically you have to go from the below. So you see a cornate uterus, and laparoscopy go from the above. You can see that. So yeah, it's HSG and laparoscopy the right answer. Next we have which of the following best describes the bony Bankert lesion. So I think you know what is a bony Bankert lesion. So if you know what is a bony Bankert, it's an orthopedic question I think. Yeah, bony Bankert lesion, and the options are avulsion fracture of the glenoid rim, stripling of the anterior inferior glenoid labrum, rupture of the inferior glenohumeral ligament complex, or it's avulsion of posterior capsular periosteum. So yeah, I repeat the question. It's which of the following is best described a bony Bankert lesion? There are so many lights I know. Yeah, which describes a bony Bankert lesion. The options are avulsion fracture of glenoid rim, stripping of the anterior inferior glenoid labrum, rupture of the inferior glenohumeral ligament complex, or it's a avulsion of the posterior capsular periosteum. Anyone? Okay, the answer here is it's basically you have to remember Bankert lesion we have seen in it's basically avulsion fracture of the glenoid rim. So yeah, in glenoid rim we see avulsion fracture of glenoid rim is basically bony Bankert lesion. So yeah, during the anterior shoulder dislocation, the head of the humerus can tear the anterior inferior part of the glenoid labrum. This is known as Bankert lesion. Yeah, it's avulsion fracture, and during the A is the right answer. It's an avulsion fracture that too during the anterior shoulder dislocation because of the trauma. Head of the humerus can tear the anterior inferior part of the glenoid labrum, which is called a Bankert lesion. Next is also X-ray. Yeah, here it is a 29-year-old man presented with bilateral weight loin discomfort. So plain X-ray KUB was done. All of the following can cause this except. So I will just tell what is the X-ray finding. So before that, it's a 29-year-old man with bilateral loin pain, loin discomfort, and plain X-ray KUB was done. So yeah, there is a basically it's a very diagnostic image. The X-ray is very diagnostic. Basically, it's a calcification. Yeah, it's a coarse amorphous calcification of both the kidneys. So now you can just tell what is the diagnosis if you can tell. So yeah, the question was all of the following can cause this except, and the options were distal renal tubular acidosis, medullary sponge kidney, sarcoidosis, or it's a Alport syndrome. So yeah, anyone wants to answer this? So it's a 29-year-old bilateral weight loin pain, and X-ray KUB was done. In X-ray KUB you see a coarse amorphous calcification of both the kidneys. Suggestive of what, if you want to tell? So yeah, the answer is medullary. Basically the question was which of the following will not show this. So the answer was Alport syndrome. Because Alport syndrome you don't see a calcification like this. You see a cortical nephrocalcification, calcinosis. Yeah. So you see a cortical nephrocalcinosis, whereas the image is showing a medullary nephrocalcinosis. That only. So yeah. So when you have a medullary, you have all that other options are right. That is sarcoidosis, medullary sponge kidney, or it's a distal renal tubular acidosis. But in Alport, it's a cortical nephrocalcinosis. So you have to remember that. So yeah, coming to the last question for today. It's a 55-year-old man comes with complaints of fever and increased fatigue. for the past week. On examination, he is febrile, hypotensive, and tachycardic. The findings of the microscopic examination of his peripheral blood smear is given below. So, what is the causative organism? So, I will just tell there are multiple ring forms. Usually, it's a RBC, and in RBC there are multiple ring forms, which is shown in the picture. So, it's a 55-year-old, fever, fatigue, and is febrile, hypotensive, tachycardia, and the finding is given what is the multiple ring forms in RBC. So the options are Plasmodium vivax, falciparum, oval, or it's a malaria. So basically you can just tell by seeing the picture only. Picture in the sense if it's a multiple ring forms in RBCs, so what will be diagnosis? You can just tell like that: vivax, falciparum, oval, or it's a case of malaria. Anyone? Anyone wants to answer this? Okay, okay. I'll just tell its answer is Plasmodium falciparum, because multiple ring forms are seen in Plasmodium falciparum. So that's all. That's all for today. So if you want to Plasmodium falciparum was the right answer. So vivax no, vivax don't see ring form. Vivax. There is basically snuff nose dots in vivax, not the no, we don't see in vivax. The answer is right. That is Plasmodium falciparum is the right answer. So we complete the 25 MCQs. So if you want to know what all MCQs are there, you can just go to the Telegram group of mine that I just given in the page, and this videos will be uploaded on YouTube as well. So thank you, and we will meet you at 11. Thank you so much.